Welcome to the Red On Smart Review Head and Neck Cancer series.
Today, we are taking on a really critical review. It's a deep dive into the world of cranial nerves, PNI highways, and the skull base.
Foundational stuff.
Absolutely. It's foundational for anyone who's treating skin cancer, salivary gland tumors, or, those really complex sinonasal cases.
And this anatomical mapping is it's vital. If you get a complex head and neck case, and I'm thinking especially about cutaneous squamous cell or adenoid cystic carcinoma.
Right.
Understanding these routes is the difference. It's the difference between a cure and, well, engineering a marginal failure right at the skull base.
That's the whole point.
So our focus today is really mapping these super efficient routes that tumors use to get into the central nervous system.
That's exactly right. Perineural invasion, or PNI, is not just a pathology word, it is geography. It is fundamentally a route problem that dictates target volume design.
A route problem. I like that.
Yeah, because when tumor travels along a nerve, it moves inexorably from a peripheral site, a primary bed, to the critical bony gateways known as the skull base foramina.
And once it gets there.
And when tumor reaches those foramina, it completely changes the entire clinical target volume, or CTV, sometimes tripling the size of the treatment area. That realization that PNI is a three-dimensional geographical problem is the core thesis of this entire review.
Okay, so to solve this, to make it practical, we can really boil it down to three essential questions. These are the three things you have to ask yourself every single time a path report says PNI on a head and neck case.
1. Which nerve is involved? We need to know the specific name and division.
2. Where does that nerve go next? You have to immediately trace its continuous proximal pathway toward the central nervous system.
And 3. What is the first skull base checkpoint, that crucial bony gateway or fossa that absolutely must be included in the CTV? If you can answer those 3, you have the case logic solved and the treatment field defined.
All right, let's anchor this. It can feel a little abstract until you see it in a real clinical scenario. We have a high-stakes case, something that is a perennial favorite on the oral boards.
Oh, yeah. This is the perfect way to learn how to connect what you read on the pathology report to what you draw on the CT planning system.
So our patient is a 62-year-old male. He is status post-Mohs surgery for a recurrent cutaneous squamous cell carcinoma and SCC of the right mid-cheek.
Okay, so already high risk just from the recurrence.
Exactly. But now, his presenting symptom. This is the absolute key. He describes a vague tingling, what we call paresthesia, and some localized numbness, and it's radiating toward his upper lip and his temple region.
Stop right there. That symptom profile, numbness, and tingling is a 5-alarm fire.
100%.
That immediately implies clinical tumor spread. The disease has, it's used the nerve sheath as a conduit and is actively messing with nerve function. That points directly, strongly toward the trigeminal nerve, cranial nerve 5.
Exactly. And the pathology report confirms it. It reports a 2.5 centimeter invasive SCC. Now, the surgical margins are clear, but the report notes extensive PNI involving a named nerve branch.
A named nerve. That's a huge flag.
The huge flag. They even sized the caliber for us, 0.1 to 0.2 millimeters.
Right. And that caliber, that's not incidental. That's large enough to support long-distance travel. The fact that we have symptoms plus a named nerve, which, based on the location, has to be a V2 branch, that confirms we are in the highest risk category.
And then the imaging just seals the deal. The MRI of the skull base, with contrast, shows explicit enhancement and enlargement of the infraorbital nerve.
Wow.
And critically, it is tracking posteriorly following its anatomical course right toward the pterygopalatine fossa. The tumor has literally mapped out its own route for us.
Okay, so the entire disease track is visible, and the patient has the symptoms to go with it. This has just gone from a local disease problem to a regional skull base emergency.
It has. So the consult question is simple and high stakes. How do you design the postoperative radiation volumes? Now let's hear the 60-second board script, the one that shows you get the risk, you get the anatomy right off the bat.
This is a patient with recurrent cutaneous squamous cell carcinoma of the right mid-cheek with clinical perineural tumor spread along V2, suggested by symptoms, paresthesia, and numbness, and MRI enhancement of the infraorbital nerve. This is a high-risk scenario because recurrence plus named nerve involvement plus radiographic spread predicts skull base failure if the proximal nerve tract is undercovered. I will immediately review the pathology for the exact extent of nerve involvement and obtain a high-quality skull-base MRI with dedicated fat-suppressed post-contrast sequences, which must be rigidly fused to the planning CT to accurately define the full proximal extent of spread. My management goal is post-operative radiation delivered to the primary tumor bed and, crucially, a continuous nerve tract clinical target volume, or CTV, following the involved V2 pathway from the midface through the pterygopalatine fossa to the skull base, including the first major checkpoint, the foramen rotundum. The dose will be risk-adapted. I will apply high-risk post-operative bed dosing while delivering escalated dosing up to 66 to 70 grays to any grossly enhancing nerve segment, all while respecting critical organs at risk, such as the optic pathways and brain constraints.
That is the comprehensive framework right there. And the beauty of that script is that it moves immediately past a vague path report to an explicit anatomically driven plan.
Exactly.
It confirms the linkage. Clinical PNI means V2 involvement, and V2 involvement means you must cover that continuous track all the way to the foramen rotundum.
Precisely. If we fail to establish that track, if we say stop short of the pterygopalatine fossa, we just aren't treating the disease. The symptoms, the named nerve, the MRI, they all align. They confirm this is a disease that requires skull-base coverage.
So treating only the primary bed in this case.
It would almost guarantee a catastrophic failure at the foramen.
Okay, let's unpack this even more. Let's reframe PNI. We need to categorize it into two really crucial risk categories.
Yes.
We can call them the two buckets of PNI.
Yes.
Because the decision to treat the skull base or not depends entirely on which bucket your patient falls into.
And this distinction, it's not academic. This is the source of so many contouring errors. If you mix these buckets up, you risk either over-radiating the skull base, which causes needless toxicity or, much worse.
Much worse.
Undertreating a disease that has already started its climb toward the brain.
Let's start with bucket A, microscopic or incidental PNI. What defines this, and what's the typical management?
Okay, so bucket A, this is the finding that it definitely increases our anxiety about a local recurrence, but it doesn't usually force us to map out a whole cranial nerve highway.
So this is the PNI you only see on the microscope slide.
Exactly. Seen only on histology, often in these tiny, unnamed nerve twigs. And crucially, the caliber is usually very small, typically less than 0.1 millimeters.
Okay.
The implication is that the tumor has only traveled a very short distance. So the clinical job here is to boost the local control probability. That means it's a strong indication for adjuvant radiation to the primary tumor bed.
Even with clear margins.
Even with clear surgical margins.
So bucket A tells you, stay local, treat the bed aggressively, use generous margins, but the risk of that tumor spreading all the way to the skull base along some tiny little twig is basically negligible.
Exactly. The risk profile is low, the journey is short, and the management stays local. Now, you have to contrast that with bucket B, clinical PNI, or perineural tumor spread.
Okay, bucket B, this is the real alarm bell. It signals that there's systemic anatomical involvement, and the definition here requires any one of four criteria. All of them point to a highly organized tumor spread.
First, the presence of symptoms. We've talked about it. Numbness, paresthesia, facial weakness. Second, involvement of a named nerve, not just some incidental twig. This confirms the tumor has reached a major conduit.
Third criterion.
Third is the involvement of a large caliber nerve, often greater than 0.1 or 0.2 millimeters, that you can see on pathology. I mean, that caliber can support rapid long-distance tumor travel.
And fourth, which we saw in our case.
And fourth, clear MRI evidence of nerve enhancement or expansion, just like in our anchor case.
This is where that highway problem analogy becomes. Well, it's literal. If you are in bucket B, the tumor is on the interstate. It has established itself on a major neurologic highway.
And you have to treat a continuous track from the primary site all the way to the brain. Ignoring that track is just a setup for failure.
Absolutely.
And for residents who are prepping for boards, the two dominant highways you must evap perfectly are cranial nerve 5, the trigeminal, and cranial nerve 7, the facial nerve.
And those two account for the vast majority of PNI in head and neck cancer.
They really do.
Let's start with cranial nerve 5, V, the sensation highway, the trigeminal nerves. It controls most of the sensation in the face, mastication. It has three big divisions that come from the trigeminal ganglion and Meckel's cave.
Right. And V2 and V3 are the money divisions for cancer spread. They're the ones we see most often.
Let's map all three, though, and their immediate skull-based checkpoints.
Good idea.
V1, the ophthalmic division. What's its territory? Why is it high risk?
So V1 covers the territory of the forehead, the anterior scalp, and the upper eyelid. PNI here is, it's most often seen with really aggressive SCC or basal cell in that periorbital region.
And the track is dangerous.
It's highly problematic because the nerve pathways are right next to the eye itself. The crucial skull base checkpoint for V1 is the superior orbital fissure. So if you have V1 PNI, you must track proximally towards that fissure and maybe even the orbital apex, and you're always, always worrying about the optic pathways right next door.
Okay. Next up, V2, the maxillary division. This is the classic mid-face highway, just like our case.
Yeah, the V2 territory is vast and it's high risk. We're talking cheek, upper lip, the maxillary alveolus, the hard palate, the maxillary sinus region.
So think high-grade sinonasal cancers or
Yeah.
aggressive cheek SCCS.
Exactly, and the danger is V2's rapid access to the central skull base through the pterygopalatine fossa, which we're going to map in detail.
And finally, V3, the mandibular division. This one governs the lower face, lower jaw, oral cavity territory.
V3 is vital for any tumors that start in the mandible, the lower face, floor of mouth, or oral tongue. The critical branches for PNI are the inferior alveolar nerve, the mental nerve, the lingual, and the auriculotemporal nerve.
And the track is different here.
The V3 track is often longer because it has to course through the bony structures of the mandible before it even gets out of the bone to track up to the skull base.
Okay, now let's switch gears to our second dominant highway, cranial nerve 7, the parotid and temporal bone highway.
Right, so CN7 is primarily a motor nerve. Its involvement is the signature of PNI in parotid gland malignancies.
Especially adenoid cystic carcinoma.
Oh, especially adenoid cystic. It has an intimus affinity for this route. It's also relevant for periauricular skin cancers. So if a patient with a parotid mass shows up with a new or worsening facial palsy or weakness,
That's clinical PNI.
that is clinical CN7 PNI until you prove otherwise. And you have to be prepared to track that disease through some incredibly complex temporal bone anatomy.
So that distinction is critical. V5 gives you sensory symptoms, tingling, numbness, pain. Cranial nerve 7 gives you motor symptoms, weakness, a droop. You can't close your eye.
Right. But regardless of which nerve it is, the presence of those symptoms means you immediately have to transition to the geographical mapping of that nerve path all the way to the skull base.
And that mapping starts by mastering the foramina.
Exactly.
The foramina are the gates.
Yeah.
For any resident sitting down to plan a PNI case or, facing an oral board examiner, you must have this checklist memorized. These are the checkpoints.
This section is just pure high-yield recall. It's got to be automatic.
V1,
Superior orbital fissure,
V2,
foramen rotundum,
V3,
foramen oval,
cranial nerve 7.
stylomastoid foramen. That's the nerve's exit point from the skull, which then leads into the temporal bone's facial canal.
And just for completeness, because we're about to talk about this area a lot, we have to mention the Vidian nerve or nerve of the pterygoid canal. It traverses the Vidian canal.
Right, and it connects the deep facial structures to the sphenoid region. It's an important neighbor.
It is. But the core three are V2, V3, and 7.
Absolutely. And to help lock that in, especially for the trigeminal branches, we use a rapid anchor phrase. V2 equals rotundum. V3 equals oval.
Say that again.
V2 equals rotundum. V3 equals oval. Getting that geography wrong is a critical error, both on your boards and in your planning.
So let's apply this. Let's walk through the anatomical journey for V2 maxillary using our anchor case. This is where contouring mistakes happen all the time.
Okay, so we start at the periphery. The infraorbital nerve, which is being compromised by that SCC in the midface, the nerve tracks posteriorly. It goes through the bony opening called the infraorbital foramen, and then it travels within the infraorbital canal. All of this is still inside the maxilla.
Okay, so far so good. You can usually see that on a CT. But the journey does not stop there in the canal.
Absolutely not. The infraorbital nerve is heading for the pterygopalatine fossa, or PPF, and the PPF is the most critical anatomical crossroads for V2 spread. We have to spend a minute on why it is such a mandatory contouring checkpoint.
So why is the PPF the definitive crossroads?
Okay, so it's a small, inverted, cone-shaped space. It's filled with fat, and it's situated right behind the maxillary sinus.
And the scary part is?
The scary part is that it's an anatomical hub that gives easy access to 3 adjacent compartments. Through the sphenopalatine foramen, it talks to the nasal cavity. Through the inferior orbital fissure, it communicates with the orbit.
And most importantly for PNI.
Most importantly, its superior wall is immediately adjacent to the skull base entrance. If the tumor gets into this fossa, it can go anywhere.
And since we brought up the Vidian nerve, how does that relate to the PPF?
The Vidian canal opens directly into the back part of the PPF. So if tumor is established in the PPF, it can spread along the Vidian nerve into the Vidian canal, moving toward the sphenoid bone.
So if you see enhancement in the PPF.
You have to generously contour the entire PPF and often include the Vidian canal as part of that continuous track, even if the primary path is V2. The PPF is the nodal point for V2, Vidian, and sometimes even greater palatine nerve spread.
So once a tumor has navigated this crossroads of the PPF, where is it heading next to actually get into the cranium?
From the PPF, the main V2 division enters the true skull base via the foramen rotundum, which takes it into the middle cranial fossa. From there, the path continues proximally toward Meckel's cave, which is the dural pocket that houses the trigeminal ganglion.
And Meckel's cave involvement, you're often only going to appreciate that on a really high-quality MRI, right? What are you looking for?
You're looking for any sign of asymmetry, a loss of the typical cerebrospinal fluid signal, or, frank enhancement around the trigeminal ganglion itself.
And if it's really extensive?
If the disease is extremely extensive or proximal, which thankfully is rarer, you then have to consider involvement of the adjacent cavernous sinus. In those cases, the imaging might show fullness of the sinus or, classically, a loss of the normal flow voids in the cavernous internal carotid artery, which confirms really serious proximal invasion.
Wow.
So that V2 PNI track requires continuous coverage of the canal, the fossa, the rotundum, and tracking all the way toward Meckel's cave.
That detailed mapping really explains why the CTV just explodes in size with clinical V2 PNI. Okay, now let's trace the V3 mandibular critical route. You see this with chin SCC or oral cavity tumors.
Right. The V3 route is conceptually similar, but anatomically pretty distinct. The most common peripheral entry point is the inferior alveolar nerve, or the mental nerve.
Which travels in the mandible.
The inferior alveolar nerve enters the body of the mandible through the mandibular foramen and travels inside the bony mandibular canal. We always include this track when we're treating the mandible, but PNI doesn't stop at the bone. The nerve continues to track back toward the main V3 trunk, which finally enters the cranium through its dedicated gate, the foramen ovale.
So the key mistake here, trap number 2, is stopping at the mandibular foramen.
Absolutely. The tumor uses the nerve sheath as a continuous protected conduit. If you stop at the mandibular foramen, you have failed to cover the route from there to the foramen ovale and then on to Meckel's cave. You have to extend coverage proximally to the foramen oval.
Okay. Finally, let's map the cranial nerve 7 route, critical for parotid cancers, which involves going through the very complex temporal bone.
CN7 PNI starts in the parotid region. The tumor tracks the nerve back toward the main trunk. This requires mandatory inclusion of the stylomastoid foramen.
That's the exit point.
That's the exit point of the nerve from the temporal bone. From there, the nerve courses proximally through the very narrow facial canal, which is this complex structure inside the temporal bone. And the track continues toward the geniculate ganglion.
And if the disease is extremely aggressive or proximal, how far do you have to track it?
In the most proximal cases, the tumor can spread toward the internal opening of the nerve, which means we have to include the internal auditory canal, or IAC.
And the IAC is tricky.
Very tricky. It houses both CN7 and CN8, the vestibulocochlear nerve, and connects right to the brainstem. If your MRI shows enhancement in the facial canal, or the IAC, you have to cover it, but you have to be acutely aware of the risk to the cochlea and the entire inner ear structures when you're treating that far proximally.
So the decision point is always, you're obliged to treat to the level that is at risk based on your imaging and symptoms. But to show mastery, even if you top at the stylomastoid foramen, you have to be able to justify why you didn't treat the facial canal. It's about showing you understand the continuous risk.
The key is that the anatomical geography is non-negotiable. Now let's translate this map into the actual planning constraints and dose prescription.
We've established the geography. Now we're in section 4, translating that knowledge into a reliable radiation plan. Let's talk about the contouring philosophy, the patch versus track approach, and how clinical PNI just dramatically alters the CTV.
Right. So if the PNI falls into bucket A, that incidental microscopic PNI, the plan is a primary bed plan.
With generous margins.
With very generous margins. We treat the local bed aggressively to 60 or 66 gray, depending on margins and other high-risk features like E&E, but We generally stop short of the skull base foramina.
But the moment we move to named nerve, clinical or radiographic PNI bucket B, the plan changes entirely to that required continuous nerve track.
And that continuous track CTV has to include the primary bed, the entire soft tissue nerve pathway, and the adjacent bony compartments, tracing that nerve proximally to the established skull base checkpoints.
This often means contouring huge amounts of tissue that you would otherwise exclude.
Cubic centimeters, yeah.
What about the possibility of skip PNI?
Yeah.
Spread that seems to jump over a segment of nerve that looks normal on imaging.
That is always the fear, and it's exactly why we treat the entire continuous track electively. Even if the MRI looks perfectly clean between the infraorbital foramen and the pterygopalatine fossa, if the disease is clinical and radiographic, the pathological risk of microscopic unenhanced disease in that segment is high enough.
So you have to cover it.
You have to mandate continuous coverage. You must treat the entire nerve conduit, or track, connecting the visible disease to that first anatomical safe harbor at the skull base.
And how do we handle it when the MRI shows gross enhancement right near the skull base, say, in the pterygopalatine fossa?
That's our escalation point. We treat that enhancing segment like it's gross disease, a gross tumor volume, a GTV, and we give it a higher dose.
And then?
We then extend the continuous lower elective dose to the next proximal compartment at risk. It demonstrates that continuous coverage logic. For example, if the PPF is hot, we boost the PPF, and then we treat the path from the PPF through the foramina rotundum to Meckel's cave at the lower elective dose.
Let's apply this directly to our V2 anchor case. How do we contour the CTV for V2 PNI? Walk us through the step-by-step process on the planning system.
Okay, so first, this absolutely requires a fused planning CT and a skull-base MRI with those fat-suppressed post-contrast sequences. The MRI is it's non-negotiable for soft tissue definition and nerve enhancement.
Step 1, defining the entry point.
I identify the infraorbital foramen on the anterior maxilla. My primary bed CTV must connect directly to this point.
Step 2, the nerve canal.
I contour the nerve path posteriorly through the bony infraorbital canal. This is relatively straightforward. It's bone-guided. You can see it on CT and MRI.
Step 3, the crossroads.
I contour the pterygopalatine fossa. And I contour this generously, making sure the entire fat-filled space is included, often bringing in the Vidian canal and the inferior orbital fissure region. This is the critical transition zone.
Step 4, the skull base gate.
From the PPF, I follow V2 as it passes through the foramen rotundum. I contour the foramen itself, and then I extend my CTV proximally into the middle cranial fossa region, tracking toward Meckel's cave, covering the region of the trigeminal ganglion.
This is a really complex volume, especially with the optic apparatus so close. What's the fundamental requirement for the technique?
The technique has to be IMRT with tight image guidance. You need the dosimetric sculpting of IMRT to create that continuous high-dose track while still meeting your OAR constraints. You simply cannot treat this area safely with 3D conformal radiation.
Okay, let's get specific on dose logic and this concept of risk-adapted dose painting. We've got 3 distinct risk levels in this volume.
Right, and we use a simultaneous integrated boost, or SIB, approach. It's ideal for delivering multiple doses to adjacent volumes at the same time.
So level 1, the postoperative primary bed, which is high risk.
We treat this to a definitive postoperative dose, typically in the 60 gray range, usually in 2 gray fractions. We'll push that to 66 gray if there are positive margins, ENE, or other high-risk features.
Okay, level 2. The grossly enhancing nerve segment, the MRI positive disease.
This is our highest risk volume. We treat it like gross disease, so we go aggressively, typically in the mid to high 60s, up to about 70 grays, so 66 to 70 grays, using that subcomponent.
And level 3, the elective at-risk nerve pathway, the rest of that continuous track up to the skull base. This is the volume we're irradiating just because of the anatomical risk. What's the rationale for the dose here, often in the mid-50s?
This is a really critical discussion. We use the mid-50s range, often 54 to 56 gray, because that dose is generally accepted to sterilize microscopic tumor deposits while minimizing the risk of severe long-term neurotoxicity.
Go to balance.
It's a balance. We know that doses above 55 to 60 grays significantly increase the risk of severe temporal lobe necrosis, especially with larger volumes, and the risk of optic neuropathy. We're aiming for that therapeutic window. High enough to address microscopic PNI risk, but low enough to respect the constraints on the adjacent brain tissue.
So it's a delicate trade-off between sterilizing the track and preventing a catastrophic brain injury. Speaking of which, what specific OAR constraints are mandatory here?
You have to list the absolute maximums for the oral boards. For the optic nerves and chiasm, we aim for a max dose of 54 gray or a V54 gray less than 5% if possible to avoid optic neuropathy.
Brainstem.
For the brainstem, we aim for a max dose typically below 54 gray, at most 56 gray. The necrosis risk just skyrockets above 60 gray.
And when you're treating V2 or V3, you're often close to the temporal lobes.
Very close. We try to keep the dose to the temporal lobes, particularly the volume getting 55 gray, as low as possible to mitigate the risk of temporal lobe necrosis, which can cause seizures and cognitive impairment years down the road.
This level of detail is exactly what shows expertise. So let's synthesize that into clear board language. How would you say that?
The definitive board language is: I will treat the bed definitively as a high-risk postoperative site, typically to 60 gray. I will treat the grossly enhancing nerve segment, for instance, the enhancement in the pterygopalatine fossa-like gross disease escalating to 66 to 70 gray. Simultaneously, I will cover the entire upstream nerve route, tracing its continuous anatomical track to the required skull-base checkpoint. In this case, the foramen rotundum, as elective at-risk tissue, typically to the mid-50s gray range.
That shows you understand the geography, the imaging, and the dose painting.
Exactly.
So when we're treating volumes that are right up against the brain, the orbit, the inner ear, toxicity counseling becomes paramount. We have to anchor this proactively with the patient so they understand the acute side effects, but also the irreversible late toxicities.
Oh, absolutely. These late toxicities are often permanent and have to be managed proactively. Acutely, sure, they get the standard dermatitis and fatigue. If the fields are near the orbit, they'll likely get acute conjunctivitis, dry eye. We need to start aggressive eye lubrication early.
Let's focus on those late toxicities, the ones that stay with the patient long term.
First, and probably the most common, is persistent facial numbness or chronic pain. Since the tumor already compromised V2, the radiation will often make it worse. We have to counsel patients that the paresthesia or numbness can worsen or even become permanent because of radiation-induced demyelination and fibrosis.
Second, the ocular risks, because V1 and V2 pathways are so close.
Yes. If the optic chiasm or nerve limits are tight, the patient has to know about the potential for chronic dry eye, the risk of keratitis, and the extremely rare but devastating possibility of radiation-induced optic neuropathy, which leads to vision loss.
And you have to tell them what to look for.
You have to explicitly tell the patient that any sudden change in vision or severe eye pain requires an immediate, urgent report and evaluation, usually with an ophthalmologist.
And third, relevant to CN7 involvement, we have to talk about hearing loss if the IEC or cochlea is in the high-dose volume.
That is a critical point. If we are tracking CN7 spread proximally, we are getting close to the cochlea. We have to counsel the patient on the risk of sensorineural hearing loss, SNHL, and we have to actively constrain the cochlea dose, typically aiming for a mean dose under 35 gray, or even lower, depending on their baseline hearing.
A major toxicity error if you miss that.
A major error.
Let's pivot now to the oral board traps. These are the mistakes that examiners are just waiting for you to make to test if you really get the anatomical application.
These three traps test whether you've moved beyond just memorizing facts to true three-dimensional anatomical understanding.
Trap 1. Treating PNI positive without asking which nerve is involved.
This instantly fails the case logic. The examiner gives you vague information to see if you panic, if you just launch into a treatment plan without clarifying if this is V2, V3, or CN7.
You're lost.
You have no business defining the CTV. You must ask, can you confirm the specific cranial nerve division involved or the named branch involved? Without that, you can't define the skull base, checkpoint rotundum, oval, or stylomastoid.
Trap 2. Stopping at the bone.
This is the mistake of not understanding the continuity of the nerve sheath. Clinical PNI does not respect the surgical boundaries of the mandible or the maxilla.
The nerve is the highway.
The nerve is the highway, and it travels into the intracranial space. If you stop your contouring at the infraorbital canal or the mandibular foramen and you fail to include the next proximal foramen rotundum or oval, you have conceptually missed the entire regional spread pattern. You've guaranteed a marginal miss that will fail years later.
Trap 3.
Confusing foramen rotundum and foramen oval.
This is pure anatomical precision failure. In the high-stakes environment of oral boards, this single mistake just works. It instantly costs you all your credibility. It implies you don't have the foundational knowledge you need to safely navigate the skull base.
It does.
So we're going to reiterate the mnemonic one more time to avoid that fatal error.
V2 equals rotundum. V3 equals oval. Lock that geographical knowledge into your permanent memory.
Okay, we're going to run through a quick board review blitz now, applying this PNI highway logic to test our recall and planning integration.
All right, let's test the retention.
Question 1. A parotid adenoid cystic carcinoma presents with new-onset facial nerve weakness, cranial nerve 7. Which skull-based structure must be included when tracking that nerve proximally, and what is the next anatomical structure beyond that?
The required structure is the stylomastoid foramen. Beyond that, tracking proximally means including the facial canal and potentially the geniculate ganglion all the way to the IAC if imaging supports it. Facial nerve weakness is clinical PNI, demanding tracking.
Question 2. You are contouring a cutaneous SCC of the chin with perineural spread confirmed along the mental or inferior alveolar nerve pathway, V3. Which foramen is the key skull-based checkpoint and what high-risk structure is immediately proximal to it?
The key checkpoint is the foramen oval. The inferior alveolar pathway maps directly to V3. Immediately proximal to the foramen oval in the middle cranial fossa is Meckel's cave, which houses the trigeminal ganglion. Your CTV must extend to cover that ganglion region.
Question 3. A mid-face SCC shows MRI enhancement of the infraorbital nerve, V2, tracking into the pterygocalatine fossa. Which foramen must you include proximally, and what is the critical anatomical structure that should be contoured generously adjacent to that foramen?
The required foramen is the foramen rotundum, and the critical anatomical structure that must be contoured generously is the pterygopalatine fossa itself, which serves as the central crossroads linking the nasal cavity, orbit, and skull base.
That blitz just confirms it. You have to master these geographical pathways. Now let's wrap this section with our clinical pearls, the high-yield takeaways for your next board exam or your next consult.
Pearl 1. PNI is a route, not just a risk factor. It is a continuous anatomical problem requiring a continuous contouring solution.
Pearl 2. Named nerve or radiographic PNI forces you to fundamentally change your treatment philosophy. Your plan transforms from a local field design to a continuous nerve tract design that covers the nerve path all the way to the skull-based checkpoints.
Pearl 3. Never make the fundamental anatomical error. V2 goes through foramen rotundum. V3 goes through foramen oval. This is your primary anchor point.
Bonus Pearl 4. The pterygopalatine fossa is the V2 crossroads. Treat this small, fat-filled hub like a mandatory checkpoint, often requiring a boost whenever V2 involvement is present due to its connectivity to deep facial structures and the Vidian canal.
Bonus Pearl 5. When treating CNVI-PNI in parotid cancer, remember that the risk continues inside the temporal bone. You must track from the stylomastoid foramen through the facial canal and be prepared to treat the geniculate ganglion or IAC if imaging suggests further proximal spread, while strictly protecting the cochlea.
The key concept remains. The CTV risk continues until you reach the next safe proximal compartment, which has to be covered in your plan.
That's the bottom line.
So, synthesizing everything we covered today, the core concept of PNI management is anatomical transformation. Named nerve and radiographic PNI changes your plan from treating a small patch of tissue to treating a high-risk, multi-compartment tract that potentially reaches the central nervous system.
We established that crucial difference between incidental PNI, which needs aggressive treatment of the primary bed, and clinical PNI, which requires covering the continuous V2 rotundum tract, the V3 oval tract, or the cranial nerve 7 stylomastoid facial canal tract. The failure point is always a marginal miss at that first major anatomical gateway.
And understanding the anatomical geography, knowing that the pterygopalatine fossa is the central crossroads for V2, and that foramen rotundum and foramen oval are the gates for V2 and V3, is just vital for successful contouring.
And our dose prescription has to be meticulously risk-adapted. We escalate dose only to the enhancing segments while electively treating the rest of the nerve highway to minimize that late neurotoxicity.
So if you get this case on boards or in clinic tomorrow, you now have the anatomical language, the imaging requirements, and the dose decision-making logic you need to design a safe and effective plan that covers the entire disease route.
Exactly.
And this entire discussion about defining the CTV track, it relies so heavily on the quality and the timing of the workup you do beforehand. You can't contour a foramen rotundum tract if you never ordered the skull base MRI in the first place.
That's right. Before you ever contour a single structure, you have to decide what images you need and when. The wrong imaging or sequencing the workup incorrectly can lead to fundamental staging errors.
Which leads us to our final provocative thought. We've mastered the anatomy, but how do we master the diagnostic sequencing? Next, we are going to dive into the workup masterclass.
Ooh, this is a good one.
We will discuss how to sequence imaging MRI versus PET-CT versus dedicated CT, the precise role of PET-CT in complex head and neck staging, and how to avoid those rookie staging mistakes that fundamentally change your target volumes before you ever draw a single line.
Because workup decisions are CTV decisions in disguise.
They are. Until then, stay focused on those foramina.
That's right.
Complete practice oral boards at radoncsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.